In May 2026, the World Health Organization declared a public health emergency of international concern for a new Ebola outbreak spanning the Democratic Republic of the Congo and Uganda. If you followed global health news over the last decade, you might be asking a fairly obvious question: didn't we already develop a highly effective Ebola vaccine? When we hear the word Ebola, most of us picture an apocalyptic, highly contagious plague. We imagine responders sealed inside heavy yellow hazmat suits, treating an airborne threat that could infect an entire room in seconds. But the biological reality of the virus is specific. It is actually difficult to catch. To get infected, you need direct physical contact with the bodily fluids of someone who is already visibly sick. We have a pathogen that requires intimate contact to spread, and we have a global health system that claims to be ready. Yet in 2026, the virus is moving faster than our response, exposing a reality that contradicts almost everything we thought we knew about our own safety. Outbreaks don't begin with supernatural curses. They start with a process called zoonotic spillover. A human comes into contact with an infected natural reservoir, most often a fruit bat, and the virus crosses the species barrier. Once it makes that jump, it moves through dense populations and across borders. People care for their sick family members, they travel to neighboring villages, and the virus hitches a ride through those close community interactions. Once contracted, the disease is brutal. Patients suffer severe fever, vomiting, and internal bleeding. In this specific outbreak, the historical data suggests that up to half of those infected will not survive. A disease that requires direct physical contact to transmit shouldn't be able to trigger a crisis on this scale, unless the medical tools we rely on have been bypassed at the molecular level. To understand why our response is stalling, we have to look much closer. Ebola is not a single monolithic virus. It belongs to a biological genus called ebolavirus. Within that family tree, there are 6 distinct species. Our vaccines were engineered to bind specifically to the Zaire strain's surface proteins, neutralizing the virus before it can enter a cell. But the 2026 outbreak is driven by the Bundibugyo strain, and its surface proteins are shaped differently. Because the vaccine doesn't find the site it was trained to recognize, it cannot attach, leaving the virus free to continue its infection cycle. This leaves health officials in a precarious position. As of right now, there are 0 approved vaccines and 0 targeted therapies for the Bundibugyo strain. We spent years perfecting a tool for one specific target, only for the virus to change the target itself. It exposes a massive gap in our ability to prepare for shifting viral threats. But the biological complexity of this virus doesn't end when the acute infection is cleared. We also have to look at what happens after a patient supposedly beats the disease. The standard medical assumption is straightforward. Once a patient recovers, their symptoms fade, and their blood tests negative, the virus is completely gone. But traces of the virus often remain in what are known as immune-privileged sites, specifically the eyes, the central nervous system, and the testes. These zones are highly sensitive. To prevent blinding or paralyzing inflammation, the body actively restricts large immune cells from crossing into these tissues. The virus exploits this defense. It seeks out these cellular sanctuaries, anchoring itself in protected environments where antibodies cannot reach it. This persistence causes a range of chronic health issues, known as post-Ebola syndrome. Even more significantly, the virus can survive in seminal fluids for over 900 days. A seemingly healthy survivor, years after recovery, can inadvertently spark a brand new outbreak through sexual transmission. It means the geographical and temporal boundaries we draw around an epidemic are an illusion. Looking at the 2026 Bundibugyo emergency through this molecular lens changes how we have to approach global health security. We cannot outpace this diverse virus family by building narrow, single-strain vaccines for every new outbreak. The future of response lies in broad-spectrum antivirals, like the experimental drug NV387. Instead of targeting specific proteins that vary between strains, these drugs mimic the basic cellular structures that all filoviruses need to attach to human cells. One universal molecule intercepts multiple strains before they can ever bind to our cell walls. The true danger of this virus is its biological adaptability. To defeat a pathogen this complex, our science must target the core mechanisms it relies on to survive.